Welcome to Measuring Return to Work. We're glad you're here. My name is Angie Hunt, Project Manager with the Work Wellness and Disability Prevention Institute, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program through the BC Government, as well as donations and memberships to WWDPI. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We'll collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website, along with the slides. You'll be emailed the direct links for all these items when they are available. As I mentioned, my name is Angie and I'll be moderating the webinar and Q&A session. Our presenter today is Ellen MacEachen. Dr. MacEachen's sociologically oriented research focuses on the design and evaluation of work and health systems and how they can be adapted to suit changing employment and socio-political environments. She has a special interest in vulnerable workers and how the growth of precarious employment conditions affect worker access to state security systems. In her research, she works closely with community partners and policymakers to ensure research relevance and improve research impact. And now I'll hand it over to Ellen.
Okay, well, thank you very much, Angie. And I want to thank you for inviting me to do this webinar. So my goal for this presentation today is to open up space for discussion and critical thinking about how we measure return to work in relation to workers' compensation. I was first approached to give this presentation at another forum last year, and my first response when I was approached was to say, "You've got the wrong person. This is a talk about measurement, and I'm a qualitative researcher. In my studies, I don't measure things. I conduct in-depth interviews, I engage in observations, I try to understand and conceptualize new territory that has not been subject to measurement, or to focus on issues that are not easily captured by measurement." But I didn't turn down that first invitation, and I didn't turn down this invitation today either. And the reason is because I had second thoughts. I thought, I have had concerns for a long time about how return to work is measured. And these concerns that I have derive from disjunctures that I see between how return to work is measured and what I see in my qualitative research findings. They don't always match up. So I feel that I've been given this marvelous opportunity to share what I see and what I know about that disjuncture. So just to be clear, my presentation today is not from a measurement expert. It's not going to provide you with detail, for instance, on how workers' compensation boards measure return to work. But what I will do is offer my insight into and my critique of how return to work is currently being measured. So in my, Angie, I'm having a hard time. Oh, there we go. Okay, I got it. So in my presentation today, I'll cover three main topics. I'd like to talk about some challenges with return to work measurement to start off with. First, ways that return to work measures can contain misleading assumptions. Next, I'd like to address the apples and oranges issue, the challenge that there's no consistent way that return to work is measured in research studies. And then I'd like to talk about dimensions of return to work that are barely being measured or not being measured at all. Next, I'll turn to political issues. What does return to work measurement mean politically? And finally, I'll turn to how we might improve return to work measures. So, moving first to the three return to work measurement issues. The first topic is about how return to work measures can contain some misleading assumptions. And there are three main issues that I'd like to draw your attention to. First is that return to work is not equal to being off of benefits. Second, I'd like to talk a little bit about administrative data, what's behind the numbers. And then thirdly, psychological explanations for delayed return to work and what they actually measure. So, A key challenge in measuring return to work outcomes is what researchers use as a proxy indicator to stand for, a key challenge is that researchers use as a proxy indicator end of benefits to stand in for return to work. Now, many people who study return to work know that end of benefits doesn't mean that you're necessarily back at work. There are other reasons why workers' benefits might end. They might have dropped their claim, they might have been cut off of their benefits, they might have been deemed able to return to work but not actually been working. And so the challenge is that end of benefits is not a reliable way to measure return to work. We conducted a scoping review recently of return to work studies published over the last 15 years. And we were hoping that when we conducted the scoping review, we'd find that researchers are moving away from this problematic indicator. We scanned the international scientific literature for English language studies published between 2000 and 2004 that focused on return to work and policy contexts. And one of our team members, Bronson Dew, led a sub-analysis where we pulled out articles that evaluated return to work interventions or return to work programs. And we found 4 studies out of our larger sample that focused on this. And then we looked to see how these studies measured return to work, to see what for these studies counted as return to work. And this is what 4 of the studies showed. There were 8 studies. And if you look at the column that I've highlighted in blue, you'll see that these 4 studies, which is half of the studies that we found, used end of benefits as the return to work indicator. So where does that leave us? The challenge is that when you're working with database information, end of benefits is often the only indicator that researchers have available. So researchers do what they can. They may write into their study that this is a limitation of the study, that end of benefits doesn't necessarily indicate that someone has actually returned to work. But the study is done. Return to work is often a part of the title in the publication. It's taken up by policymakers and others as a study of return to work. So this leads us to the next question. Is it better to do this research knowing its limitations or no research at all? And I would say, well, let's try to use other indicators. So let's look at the other ways that return to work was measured in the other slides. So the other 4 studies used outcome measures for return to work that were closer to actual return to work, including these 2 American studies that looked at actual earnings records and others that looked at actual working hours. So it is possible to use other measures as a proxy for return to work that just don't focus on end of benefits. Now let's turn to other aspects of how return to work is measured. So we know that researchers make use of existing records to help them to gauge the success of return to work programs. And another way that existing records are used is when looking at program outcomes, such as whether workers have received services and so on. So in this example, I'll refer to my study that I conducted of the labour market re-entry system in Ontario that provided vocational retraining for workers who could not return to their previous employment, normally because of a permanent injury that didn't allow them to. So in Ontario, the labour market retraining program was humming along with outputs that the Workers' Compensation Board there would have been pretty happy with. Workers were being retrained, they were being successfully upgraded to get high school diplomas and to complete their vocational programs. At the end of this process, they were deemed employable. Well, you can see this measurement problem again. Being deemed employable is not the same as actually returning to the labor force and being employed. But on the other hand, it could be said, the WSIB in Ontario could have said, well, we did our part with providing retraining. The rest is up to workers' motivation. But then another measurement problem existed. The problem was that many of these workers who looked on paper as if they were being successfully retrained were not necessarily getting this education. the return to work or return to labor market program success, measured on education success and completion outcomes, was actually based on misleading numbers. So our study that involved interviews with providers of labor market reentry services and workers in the program was able to get under the numbers to see what they really meant. We heard providers telling us how they got workers through their high school diplomas by going at a pace of 2 months per grade. They told us that they did this by teaching only the core threads of the programs. At the time of that study, I had 3 kids in high school. And so I suggested to them that I'd put my kids into their schools and we'd get high school over with quickly. But their response was, oh no, don't do that. They mentioned that if they didn't offer very quick upgrading services, then the contract from workers' compensation might go to someone else who would do it faster. So what kind of high school completion is this really? And were injured workers really getting an education? There was one worker who described to us how he had become a genius by going through this process. He'd never been great at school, but here, if he wrote a test and he didn't do it well, the teachers helped him to rewrite it until he got top grades. So at the end of the day, he looked great. He had top grades and the school looked great too. All of their students did really well on exams. So this is another kind of return to work measurement issue that we have to be careful about. You have to know the story behind the numbers. Another measure that's quite popular in return to work research and among workers' compensation boards is fear avoidance in workers. It's supposed to measure fear of movement and back pain patients as an obstacle to recovery and return to work. And here is the basic model. You can see on this slide that there's negative affectivity, pain, catastrophizing, fear, avoidance, depression. And on the other side, the idea is to move to no fear, confrontation, and recovery. Now, back pain and return to work is a challenge for workers' compensation boards, especially when there's no clear objective evidence. And it can quickly draw providers to psychological explanations for why workers are not returning as expected. And you can see here I've put up the musculoskeletal program of care put out by WSIB in 2014. And they refer on this page to yellow flags that are normal but unhelpful psychological reactions to injury. And they draw attention to fear avoidance and to the fear avoidance beliefs questionnaire. And built into this fear avoidance measure is a conception that avoidance of movement is related to an irrational fear. It's the workers who are overthinking pain. And a challenge is that it leads to certain types of interventions, for instance, encouraging the worker to be more confident or cognitive behavioral therapy. But if you look at what's actually measured in the fear avoidance model, you can see that questions are all about pain. So for instance, my pain was caused by my work, or my work is too heavy for me, my work might harm my back, and so on and so forth. But what if the worker does have a fear of return to work, but it's not irrational? For instance, what if the pain is extreme? Or what if they know that the employer has still not fixed that shelf to the wall that fell on top of them? It's important for us to know that in policy, at least in Ontario's Workers' Compensation Board, there is no requirement for employers to fix the aspects of the work employment environment that caused a work injury. Sure, their workers' compensation premiums will go up if there's lost time for workers, but there is no requirement for them to fix that issue that caused the injury. So I say, based on my years of research with injured workers with complex and long-term claims, that there is no reason to think that pain is necessarily irrational. And in fact, other researchers are starting to publish papers that talk about this too. They're saying that basically that even though this measure, the fear avoidance measure, is very popular, it's not particularly well founded. And so here I have an excerpt from this study by Weidman and al. And they talk about how nearly 20 years ago, this fear avoidance model was advanced to explain the development and persistence of disabling low back pain. And it's become the leading paradigm for understanding disability associated with MSK pain conditions. But they go on to say that despite the endurance and population of this model, the level of empirical support remains unclear. Prospective studies have failed to support the supposed sequential relationships. The validity of several fundamental assumptions that underlie these cyclical relationships have yet to be fully examined, including the characterization of fear as phobia. So, in my studies, I've encountered workers experiencing pain, and in some cases, it may have been overthinking. But it may also have been in relation to the environment that they knew they were going back to. I've had so many workers tell me how they took oxycodone so they could manage the modified work that they'd been assigned. They were desperately afraid of losing their jobs. Or they might have had experiences of their functional limitations not being observed by their supervisor at work, which led them to being re-injured. These people could complete the fear avoidance skill that I just showed you and say yes to everything and be considered as having a psychological problem when actually they may be being incredibly direct and rational. So I've given you a few examples of the issue of how return to work measures can contain misleading assumptions. And now I want to turn to the problem of inconsistent measurement of return to work. And once again, I've chosen 3 examples, and I'll focus on differences in time point for measuring return to work, interpretation errors in relation to return to work duration and medical assessments, and differences among who reports and for what. So let's return again to that scoping review that I referenced earlier and look at the column on the far right that I've highlighted in blue. And we'll see here that in these studies, return to work was measured in a variety of ways. And one of the differences is the length of follow-up. So, for instance, if someone returns for 2 weeks and then is off again, does that count as return to work? What are we really measuring with our different cutoff times for what counts as return to work? So if you look at these studies here, some of them are pretty good. They measure return to work at 12 months or 24 months. But then there's one that's fairly brief at 3 months. And then another issue is 3 months or 12 months after what? 2 of these studies are 12 months since surgery. Another study is 2 years since enrollment in a return to work program. So the point I'm trying to make here is that there are lots of different ways to measure time to return to work. And when we're trying to add up the evidence across studies, it can get quite complicated and difficult to draw conclusions about what's effective and what works when we're measuring things so differently. Some researchers in Australia, Fiona Clay and her group, refer to the problem of researcher interpretation errors. Some compensation schemes require employers to pay sick leave wages for the first 2 weeks before the compensation scheme kicks in with income replacement. So injuries of less than 2 weeks don't show up on the claims data. But for instance, in Ontario, they would, because workers' compensation income support benefits kick in for the first day of missed work. So with the same length of time away from work, let's say 4 weeks, in Ontario, the administrative data would look like we have workers off for 4 weeks, while in Sweden, they would have been only on the compensation scheme for 2 weeks. So that's the interpretation error that we see when researchers don't understand, for instance, policy differences between jurisdictions. And certainly many systematic reviews that I've seen that include multiple jurisdictions don't include some of this critical local system information. In this study here, the one by Catherine Lapel et al., they refer to these kinds of errors as well. They studied the relationship between return to work and medical gatekeepers, and they paid attention to jurisdictional differences. And here's the quote that I pulled out for you. They talked about how gatekeeping roles differed between jurisdictions, both at initial adjudication and in dispute processes. Quebec legislation gives greater weight to the opinion of the treating physician. And policymakers, they go on to say that policymakers should contextualize the sources of the evidence that they rely on from intervention research, because findings that they have may reflect a system rather than an intervention effect. Researchers should consider policy context to both adequately design a study and interpret their results. So what this means is that differences in assessments of workers with back pain in Quebec and Ontario may not be due to differences necessarily in how, for instance, family doctors assess the problem, but rather to differences in what kinds of assessments are accepted by the Workers' Compensation Board. For instance, in Ontario, more independent medical evaluations can have an effect on return to work statistics and decisions. So now I want to turn to differences in who reports and for what. Another example in relation to consistent return to work measurement is that when we're measuring return to work, we need to consider who is eligible for compensation and who isn't, and for what people are covered. For instance, for workers' compensation in Australia, mental health is covered. But in many jurisdictions, for instance, in Canada, we have very little coverage for mental health in relation to work. In some provinces, the Compensation Board may strongly consider pre-existing conditions when considering entitlement to compensation, while in others, they may not. And then when measuring return to work, we need to take into consideration the reporting issue. Who reports work injuries? And there's a mounting evidence base that people are increasingly reluctant to report for fear of jeopardizing their scarce and precious jobs. We see this among people who are precariously employed. We're also starting to see this phenomenon among unionized workers. And in a study that I conducted recently of female pre-tenure faculty members at a university, we found them stifling health complaints for fear of jeopardizing their future employment and tenure with the university. So these are some of these differences that can become invisible in studies, leading to conclusions that are mixing apples and oranges, basically. These invisible issues, as I've mentioned, are differences in time points for return to work, differences in workers' compensation schemes, and in who reports and for what. So now I'd like to turn to the third section and talk about some dimensions of return to work that are not or barely being measured. And I have this picture here of some ostriches with their heads in the sand. And that's basically what I'm trying to say, is that there are some issues that we're just not looking at, and it's as if we have our heads in the sand. And these issues are quality of that I'd like to talk about right now, are quality of work return, prognostic factors in return to work effective providers, and the role of gatekeepers. So, one of the dimensions that's barely measured is the question of return to what? Are we measuring that the worker returned to the job that they had before or to an equivalent one? Or are we simply measuring that they're employed without knowing what kind of work workers have returned to? So for instance, if a worker worked in construction and they were earning $60,000 a year, and they ended up, after their injury, working as a gas station attendant at minimum wage, how do we measure this as return to work? Or let's say we have a worker who is injured and then does return to work and appears to be earning similar wages, at least during the measurement period. How do we know anything about the quality of the job? For instance, what I've seen in my research is people being injured when they had solid full-time jobs with benefits, then leaving the labor force because of their injury, and then coming back often at middle age, but only being able to get contract job work. So this is sort of jobs with no benefits and very little income security. So the salary may not be that different than what they're in before, but the conditions of work are very different. And so yeah, that's my basic point, is that we need to think about the quality of work that follows injury. Another issue that's barely measured is the effect of the providers on return to work rather than the characteristics of the workers. So when I say studies of prognostic factors for return to work, and these are factors that predict which workers will tend to return, the factors are all based on the individual worker. Studies will focus on what is it about that worker that may delay the return to work. And they look at things like gender, date, type of injury, type of job, and so on. But what about the effect on their return to work, for instance, of the insurance agent that they dealt with? It's rare to see studies that focus on this. However, there is qualitative research that's starting to look at this, my own research included, and also research by Beth Kilgore in Australia, for instance, that focuses on case managers. And so the issue is, if we want to understand return to work, should we not also be measuring the people delivering the product, so to speak? So we are beginning to see a little bit of this research. In the last couple of years, some papers have been published that focus on the role of healthcare providers. And again, much of this is qualitative work, and I've provided a reference for you here of some very recent work put out by Iggy Cosney. But when measuring return to work and focusing on providers, very few studies get into the issue of variance among providers. For instance, what kinds of healthcare providers are providing return to work determinations? We know, for instance, that in Ontario, determinations of fitness to return to work are made by various kinds of medical assessments, including the so-called paper review by physicians who are funded through the Workers' Compensation Board. And for those of you who are not familiar with paper reviews, they're file reviews conducted by healthcare providers who don't see the worker face to face. And the point is that there are many different ways of determining when someone is ready to return to work, and it's not black and white, and it can be expected to vary by jurisdiction. And so to really understand return to work measurement, we need to know as well how providers play their part. A study that was published in 2016, conducted by a group at McMaster University in Ontario, helps to make this point. They conducted a systematic review of studies of disability evaluations, and one of their key findings was that there were differences in assessments between experts, such as independent evaluators, and health professionals with a mandate to care, such as treating physicians. And I pulled out this quote for you here, where they say, despite their common use and far-reaching consequences for workers claiming disabling injury or illness, research on the reliability of medical evaluations of disability for work is limited and indicates high variation in judgments among assessing professionals. So once again, more attention needs to be placed on the broader system and in which return to work plays out. So moving now to the next section of the politics of what gets measured. At the beginning of the talk, I mentioned that I'd talk about the politics of return to work measurement. And my main point is the old adage that what gets measured gets managed. So if we don't measure something, it doesn't exist on paper, it doesn't get resources applied to it, and so on. And I would argue that worker mental health can fall into that domain. And we may measure some things, but we may measure it in such a way that we're drawn to certain kinds of outcomes and not others. This will shine the light on some issues and cast a shadow over other issues. And these days, I would say that we have a dark shadow cast over people who are deemed ineligible for benefits. We don't know enough about who is being denied and why. When we talk to people in legal clinics, they talk about issues of workers being denied workers' compensation benefits because the board says their injury is due to pre-existing conditions, but we don't know the extent of this problem. We also don't know enough about worker re-injury following return to work and about the whole issue of time to heal. So the final section now, how can we improve the measurement of return to work? The first suggestion that I have is to consider context. So to help with interpretation errors, we can design and interpret measures in light of contextual conditions. And so I'm just going to make a little plug here for a book that I'm editing that will be coming out either this year or next, called The Science and Politics of Work Disability Policy. It has chapters from researchers across 13 countries. And in each chapter, the author explains their work disability outcomes in relation to the country's context, the policies and laws, as well as the political conditions and employment conditions. And these are the types of analyses, I believe, that are needed to provide a foundation for return to work measurement studies. My second suggestion is to measure more than the worker. As I mentioned in relation to prognostic factors, so many studies are focused on the worker and what's wrong with them. What would we learn if, for instance, we included case managers or workplace supervisors in return to work measurement? What more could we learn if we focused on the broader context? What about measuring workers at the fringes? Large studies of return to work, usually quantitative, they need large samples, and then they'll often focus on the average worker. That's where you get the large samples. And we do know that in general, most workers who are injured on the job recover and return to work without a problem. But another approach is to focus studies on workers with the greatest need. So many of you will have heard of the old standard formula, the 80-20, that 80% of resources are consumed by 20% of workers. And I argue that we need to do more to understand the situations of those 20% who face difficulties with return to work. Standardized measures is another thing that we can improve on. The McMaster Research Group that I just mentioned to you that conducted the study of disability assessment strongly recommended more standardization of disability assessment to improve reliability in expert judgments of work disability. In their study, they noted that across OECD countries, about half of all claims are denied, and they suggest that fairer evaluations might be achieved with standardized instruments. Linked databases is my next suggestion and my final one. And this issue has come up so often. If we could link workers' compensation claims to welfare disability claims, to income statements, and so on, and develop an ability to follow workers as they travel across systems, we could get an idea of what happens to workers after work injury and what kind of work they return to and for how long, and whether they end up on other benefits. That would be so helpful. And there are some excellent researchers who are really trying to create these linked databases, in particular in British Columbia, and I'll mention Chris McLeod and Mika Cohorn, who are two leaders in this field. So just to wrap up, what I've tried to do with this presentation is to open up a discussion on measurement of return to work and to provide some examples of return to work measures that contain misleading assumptions, that are inconsistent, and areas that are undermeasured. And I've also tried to point out ways that we can overcome these issues, because they're not insurmountable. We can be sure that proxy indicators are valid. We can have to aim for consistent measurement and take consideration of the policy and the social context to help us to avoid interpretation errors. We can focus on more than workers. We can focus our studies on the providers, the gatekeepers, the work environment, and we can keep working to try to share and link databases across ministries. So that wraps it up for me. I want to thank you for your attention, and I welcome any questions.
Thank you. To our audience, if you have any questions at this time, please enter them into the question box on the GoToWebinar panel, and we can read those out loud. And some questions that came in. In all of your studies, is there an industry standard measuring return to work or general guidelines to follow that you thought were best?
Oh, that's a great question. Unfortunately, no. I have not seen any industry standard. And in the book that I'm editing that will be out soon where we look at return to work across 13 jurisdictions, mostly Australia, New Zealand, European countries, Canada, USA. Um, there is no standard across these countries as well. And that's one of the things that we want to talk about in the book. In terms of what could be done is that if you take consideration of, if researchers who are studying return to work really understand the policies and how return to work is being measured, when benefits are provided by provinces, for instance, then they can calculate the differences properly. They can take into account that in one jurisdiction, benefits kick in after 2 weeks, and another they kick in after 1 week. So it is possible to calibrate and to adjust across jurisdictions so that you have accurate measurements, but you need to be able to know the policies, and that requires a lot of extra work.
Another question that came in your studies, did you find there was a proliferation of definitions of disability as a possible issue for standardization?
Yeah, it's really interesting because Germany is a jurisdiction that has really tried to standardize and create communication across different providers in their systems, for instance, between employment insurance, disability insurance, sickness insurance. And one of the things they did a few years ago was bring everyone on the same level with the same definition of disability so that the ministries could actually speak to each other. Really smart move. I haven't seen this elsewhere. I know, for instance, in Canada, and I'll take Ontario because I know it so well as a province, that workers' compensation will have one definition of disability, private insurers will have another, and then the Ontario Disability Support Plan will have a third definition of disability, and it drives people nuts. It's very difficult for healthcare providers to keep filling out all these different forms. It's difficult for workers, and it's difficult for these different systems to communicate with each other when it's basically it's apples and oranges. So it is possible to develop a standard. Germany has done it, and we can do it too. And I'm just trying to recall what standard they used. It was an international standard that they chose to use. And I don't have it right at my fingertips right now.
And another question that came in, you mentioned the lack of linked records in Canada. Have you noticed, are there the beginnings of linked records in Canada that we can look to, or one repository of return to work information that might be bigger than the others?
Yeah, BC is a leader in linked records in Canada, and that's because of agreements between different authorities in BC, WorkSafe BC among them. They are the ones who are really leading the charge on that, and that's why BC researchers are the ones that know most about this. And for instance, some of these researchers are collaborating with jurisdictions in Australia as well to try to do a lot more comparative analyses across, for instance, workers' compensation boards across different jurisdictions.
In your studies, have you found any measurements for organizational factors on bullying or leadership?
That's a really good question, and I don't know. I am sure there are measurements for these organizational factors, but I really don't know because the challenge is that I'm not a measurement person, and so the issues that I've raised in this talk today are things that keep coming up in qualitative research that people aren't measuring or thinking about, that the measurement people don't seem to be taking up. So I don't know about particular measures that exist for bullying and leadership, unfortunately.
I think that's all the questions that we had come in at the moment. Dr. MacEachen, is there anything you'd like to add following your presentation?
Great questions. I hope everyone, found the talk useful for them in their own ways, and thank you for inviting me.
Yes, and thank you so much for your presentation.